welcome back. We are now going to switch gears from the Shining Star to home support, home health. I'm so sorry. Always going to get that confused, I'm afraid. And I'm delighted this morning to introduce two folks from home health. The first one we've already met in the first segment here. Welcome back, Stephanie.
Thank you. Thank you.
Stephanie Santiago is the office coordinator.
Yes, ma'am.
Jennifer Martin, our second guest, is the clinical manager.
That's right.
of home health. So let's begin with you, Jennifer. Tell us what you do, and then you're going, I think, to have a short update.
Okay. I oversee the clinical operations of Certified Home Health, and Certified Home Health is our skilled division of support in the home. So we have registered nurses, physical therapists, occupational therapists, speech therapists, and we all work together, and aides, certified nursing assistants, we all work together to promote the well-being and restore the health and best function of our residents here when they need us. So that's a bit what we do, and I oversee the daily management and operations of our division.
Remind us, Jennifer, this is the kind of thing that Medicare does cover. All of these services. They traditionally would be used by people coming back after hospital stays.
That's true, but not always.
Not always. Tell us the kinds of situations.
Sure. And that is a misunderstanding. Medicare does cover home health 100%. There is no copay for home health as long as it's medically necessary. You don't cap out of home health during the year as long as it's medically necessary and you meet criteria such as you are homebound, you're not easily able to access outside therapy groups and such as that. And so we actually come into the house if you're unable to go out. And we also want to make sure that the patients who are receiving the care have the support they need in the home. So if we go in and find that a resident who perhaps has just come out of the hospital and does have a strong support system, or sometimes a resident has just declined with the active disease process, perhaps they're acutely ill, perhaps they had pneumonia and have not been hospitalized, but they're at home in a debilitated state, we would then certainly go in for such things as that. Any situation that causes a resident to be ill, so not their normal healthy selves, and we can go in and help to maintain that or restore that for them. So if they have a great effort going out and about, it's difficult for them, they need medical equipment, they need human assistance, or quite frankly, they perhaps can't even get out of the bed, we're there for them. And for a lot of residents, this is quite overwhelming because they're not used to that, especially here at Green Spring where we're happily aging in place. You may be used to being young and vigorous and enjoying your retirement.
Or even old and vigorous.
Exactly. It's all relative. Perhaps you might fall, heaven forbid, and sustain a fractured hip. Well, that's certainly something you're not used to. You're used to being very vigorous and doing community activities. But for that period of time, you are not able to do that. So the doctor might call us and have us come in to do your physical therapy, perhaps educate you on your medications, or perhaps congestive heart failure, perhaps chronic obstructive pulmonary disease, a number of disease processes. If you've had an acute exacerbation of any of those, we'll come in and teach you how to self-manage. And that's our goal, to teach the resident how to self-manage their disease process, restore them to their prior functional level. So home health is something that I think has a broader range or scope than some people expect it to be. You don't have to be fresh out of the hospital. You don't have to be fresh out of rehab or a skilled facility. If you have had a decline in your health status, we can certainly go in as long as you meet those homebound criteria and it's medically indicated.
All right, I think, yes, you heard me saying after the hospital, I think that's a misconception that we all do have, that it is after an acute care setting. Or the rehab setting. All right, well that's very helpful. And I think we feel terribly fortunate here at Green Spring to have the kind of team that you all really represent.
Thank you.
It is an amazing service.
Thank you.
Is there anything, now I know you went through, or at least as I recall, you went through an accreditation or certification or approval ranking fairly recently.
We do. Medicare is, we're very tightly
regulated.
Very tightly regulated by Medicare. And so they periodically will send surveyors out to make sure that we are following regulations and that all is as it should be. The conditions of participation are set by Medicare and must be strictly adhered to in order to maintain your certification with Medicare.
Is it certification? I wasn't sure.
It's a Medicare certification.
Right.
It certainly is. And we just went last year through a recertification through Medicare where this Medicare surveyor came in. And then corporate just recently, a few weeks ago, supplied a third-party surveyor to come in and do an audit to make sure we were doing the things we were supposed to be doing, just as a practice run, you might say. And we did very well with that, too. So Green Spring and the Erickson community are very serious about supporting us so that we can maintain the strictest of adherence to our guidelines and regulations.
Well, that's reassuring to hear.
Exactly. And we are very proud of that status, and we treat it very seriously. So sometimes people might have a question about, am I homebound or am I not? I'm not sure. Well, Medicare leaves it to the agency and the clinicians to determine, is this particular patient homebound? Do they meet that criteria? So many times we'll go into a home. If you're not sure, the doctor's not sure you meet criteria, we'll go in and we'll help you determine that. We'll sit with you, we'll interview the patient, we'll discuss what they're able to do, what they're not able to do. If someone was going out for, say, they're going out to play bridge, or they're going out golfing, or they're going out shopping, or to a restaurant, or concerts even, they clearly could access outpatient care. But if you're struggling to get out of the home and you're not out socializing, you're not up to doing that anymore, you're too weak from a disease process, you're not able to safely walk, you've been having a lot of falls lately, and we need to strengthen you, very likely that patient will qualify for homebound. So we'll determine that well within Medicare's guidelines. And if there's any doubt, we will discuss it with the physician and the patient and the family, and we'll sit down and build a plan of care together.
How large a team do you have?
We have about 20 certified or certified clinicians, therapists, and nurses, and nursing assistants, about 20 of us on the team.
About 20. Now, hospice is independent of your unit, is that correct?
Hospice has its own certification. They are independent of home health. However, we do work hand in hand. Sometimes our residents are nearing their end of life, and we help to transition families from perhaps home health. If we see that a patient is declining, or perhaps they just want to talk about hospice, they're not sure. It scares them a little bit.
Of course.
So we'll talk to hospice and have a representative come and just sit down and have a chat with the family and decide whether it's best for them or not. So we do work hand in hand. Sometimes patients are in hospice and they graduate from hospice. They start to do better and they come back to home health if needed. So it's a two-way relationship, and the doors are very open.
All right. And you also then clearly have a relationship with home support.
Definitely. We often will go into a home where someone used to be independent, but clearly they're not right now, and they need some support, custodial support in the home. And custodial support means perhaps they need someone to prepare meals for them, or do some house chores, or maybe just escort them down to the medical facility here. So if they need those non-clinical skills, we would go to home support, connect them with the families, and they can decide together what's best for their family member.
All right. Well, that all certainly ties it up for us, I think, in terms of conceptually. There's always been confusion, and I'm sure always will be confusion between home support and home health.
And home support is private pay, and Medicare covers home health services, and that's one of the big differences to remember.
Yes, and it's skilled skilled care versus general care?
Well,
would that be a fair assessment?
Not always true, because there's a caveat there. With home support, they do have nurses that will oversee patients' medications for them. Medicare
do they under home
Medicare
support?
considers that
I didn't realize.
custodial care, and the patients are out doing concerts and they're out and about in the community, so they're not homebound. They're
Right.
not particularly ill at that moment, but they're having some trouble managing their medications.
Right.
And so you can hire a nurse to come in and help manage those medications for you. So they do have a highly, excellent team of registered
Didn't
nurses
realize
on
that
their
was under
staff
home
as
support.
well. Right, so we do work hand in hand. They do the custodial ongoing care to support the family member, and our purpose is for essentially rehabilitation of a chronic or acute disease process, but we also can maintain things such as people who are homebound but have Foley urine catheters in and things like that, and we'll always do that. So it depends on the individual, and I would have to say that we will assess that individual for their needs, that nobody falls into a cookie cutter. Everybody has specific individual needs. They may be strong in one area and weak in another. And so we do work as a team. We're very closely located. We work as a team to provide whatever services that individual might need and agree to.
Closely, your offices are located.
We are on one
together.
end of the hall, and home sports at the other end of the office,
end of the hall.
and
All
hospice is right across the street.
All right, all right, all right. So literally, you are.
Yes.
All right. Now, Stephanie, I didn't mean to be ignoring you, but since we talked pretty much about your employment here in the previous section, I haven't done it. Now, is there anything you'd like to add in terms of your work in the unit?
Okay, well, I essentially do all the non-clinical aspects of office work, all the office duties, and
again, we know you answer the phone,
yes,
and you
ma'am.
are the voice on the phone.
Yes, ma'am. And I do the billing for Medicare as well as
Oh, you do?
Yes, ma'am.
That's got to be a major issue.
It is, and she also manages all of our supplies, and she's the gatekeeper of all the phone calls that come into the office, and the message taker, and she is we call her our Radar O'Reilly. If you remember the MASH show.
I do remember
She does
Radar
it all.
O'Reilly.
She does it all. So we depend on her every day, every hour of the day.
That's a wonderful designation,
Yeah.
to be Radar. I like that a lot. We all, of course, loved him in MASH. All right, well, Stephanie, that's an incredible job. What do you do after hours, by the way, in terms of answering phone calls?
We have an on-call system 24 hours a day, 7 days a week. So if someone had a concern after 5 when the phones are turned over to the on-call system, and you would speak to the on-call company and they would route their call to the nurse on call.
To the on-call company?
Yes, we actually, the calls at night go outsourced to a company that specializes in on-calls for physicians and home care agencies.
Oh.
And they'll receive the call and direct it to the registered nurse or whichever clinician happens to be on call for that week. And we go by the week.
All right, so you're a 24-hour service.
We are, and even on the weekends, if someone came out of Garden Ridge or the hospital on Friday and needed to be seen that weekend, we would be there that weekend for them.
All right, so your services actually are provided then on
Right.
weekends and okay.
Right.
All right, well that certainly makes it terribly convenient for folks.
Well, it's necessary when you're dealing with a community that's fragile or might need medical care at any time. Of course, we don't deal with medical emergencies. Green Spring has the cord system security for true medical emergencies. People who needed that emergent care could get it here very, very quickly. But if you had called us and said, my Foley catheter's not draining, my dressing came off, my wound dressing came off, I'm so confused about my medications, then we certainly would come and visit you. But the emergent calls are safe for pulling that cord and get the emergency system activated.
All right, well I know you provide that your physical therapists, occupational therapists, and that all of them work on the weekends too.
We do have a team that works on the weekends as well, and so it's very rare that we can't accommodate something that's necessary on the weekends. Their normal hours are Monday through Friday, 8:30 to 5, but because of the on-call system and also because of the flexibility of some of our therapists, we're able to accommodate most needs on the weekends as well.
All right. Well, again, it's a marvelous service to have it this convenient and available. I think is just kind of amazing. Anything you'd like to leave us with here, I see that our time is about up. Do you have any plans for changes in the future? I mean, are you seeing maintaining what you're providing now? Do you see any changes?
Well, there are
coming
always changes on the horizon with Medicare. They're instituting a 5-star program, which is a rating that will be publicly announced, and people can go on the Home Care Compare site, and they'll be able to see how many stars your agency rates, and it's not typical.
Is that right?
It's not typical like a hotel 5-star rating or something.
Right.
If they're comparing it again's all the other agencies that are in the area and the statistics of all the other agencies. And so that's new, and we also have ICD-10, an entire new medical coding set that's starting in October 1st, and I think the medical world in America is just nervous about that. The rest of the world embraced it years ago, and we are the last nation in the world to embrace ICD-10. That starts October 1st, so people are scrambling to be on top of that. And then
could you give us a few details about that?
Oh, sure. The coding set is what drives financially the money and categorization of the care that's being delivered in America. We formerly were on the ICD-9 set, and that limited how you could describe a code. But with ICD-10, you'll be able to say the person has diastolic heart failure, acute on chronic, with pneumonia or something like that. You'll be able to expand the code and drill down to what that patient's particular needs are. And it's just more exacting. They've also left placeholders in those codes for new diseases that are going to come up. It's expanded greatly our ability to be accurate with our patient diagnoses. And the diagnoses in the home health world actually help to drive the reimbursements from Medicare. How seriously ill are your patients? How much care might they need? They equate that with the OASIS system, which is our ability to categorize a particular patient's disease process into quantitative format, and then that spits out a dollar amount that Medicare will pay the home agency for services.
All right, so this is all more precise.
It's very precise, very calculated.
Makes absolute sense. Stephanie, Jennifer, it was terrific. You were both so helpful and great in your explanations. Thank you for coming today.
Thanks for having us, Marcia. It was a lot of fun.
It was good for us too.
Good.
Thank you.